Last but not least, we're going to talk about schizophrenia. If you turn to 561, some of you may have seen schizophrenics before. You know something about schizophrenia. I am not an abnormal psychologist, a clinical psychologist. We have a number of symptoms for people who have schizophrenia. I didn't see in your book they're classified as, sometimes they classified into positive and negative symptoms. Your book talks about the 4 A's: inappropriate emotion, disorders of thought, ambivalence about things. We see problems with speech. You can look on 562 and 563, and actually do me the favor, look up the positive and negative symptoms. But schizophrenia seems to be a real disorder. It certainly affects people with hallucinations as well. One of the main hypotheses for schizophrenia was that maybe there's too much dopamine at work. And if you remember back to cocaine or amphetamine psychosis, those disorders are based on having too much dopamine in the system. And the idea is, especially dopamine in that mesolimbic tract, the nucleus accumbens, that if you actually have that going on, you can start looking like you're having psychosis. And so in many respects, too much dopamine may be part of the problem with schizophrenia. And once again, if you look on 566, you can see the idea, once again, of where receptor pharmacology has led us. We now know that there are a lot of different receptors that are involved in dopamine regulation. You can see on 555 and 556, they talk a lot about receptor specificity there. You can certainly look at that a bit more. One of the ideas put forth is that maybe if we have drugs that work with specific receptors there, that we can fix the problem. And you can see they talk about clozapine there and so forth. You can get receptor specificity and not cause all the side effects for things as well. So that's one of the main ideas. Oh, there it is. It looks like on 564, positive and negative symptoms. There was another very interesting hypothesis about this, positive and negative symptoms. Let's see if I can find this in the book. There it is. It looks like it's page 570. One of the more interesting hypotheses that really gets at kind of this idea of reductionism. It seemed a lot of the positive symptoms that were occurring. And if you look back in your book at that section, the positive symptoms showing too much of various behaviors, that one hypothesis is that that is related to too much activity in the mesolimbic system, which has a lot of that dopamine, if you remember, for psychotic behavior. The other idea is maybe the positive symptoms are caused by that. The negative symptoms maybe are caused by not enough dopamine activity in the prefrontal area of the brain. Prefrontal is the idea that there's dopamine there, and maybe all the negative symptoms, the flat affect and so forth, were due to a lack of dopamine there. This is a very behavior receptor specificity idea, a mind-body idea, the idea of type reductionism. If that idea is correct, or the hypothesis is correct, the idea would be to try to take a drug that decreases dopamine in the mesolimbic tract and increase dopamine in the mesocortical tract. Unfortunately, I believe it's not nearly that simple. They've tried some of these ideas and have had some mixed effects. More to the point of things they've actually tried, they do a lot of neuroimaging to see what goes on with the brain. There does seem to be a genetic component to schizophrenia as well. So dopamine products are mostly used to treat the problems, and obviously if people go psychotic in any sort of way, they try to use some of the drugs to sedate people that we talked about in the previous unit. Last but not least, and I'm going to make one more recording after the discussion boards here, I wanted to talk a little bit about obsessive-compulsive disorder because I asked you to do some research on that. Once again, can you actually take a disease state like obsessive-compulsive and reduce it to an exact neurobiological locus? Can you say, well, there's too much of the serotonin receptor, the HT3 receptor, or the A receptor? That seems to be difficult to do. We do find that there are problems with serotonin, certainly with obsessive-compulsive. I have attached an article that I just wanted to cover for a few minutes here to kind of share with you some of the things going on obsessive-compulsive disorder. I'll ask you to kind of summarize this for your write-up. They talk about how you define obsessive-compulsive disorder, so I would ask that you do that. Looks like they have on the first page a meta-analysis on the 4 major symptoms going on. Page 403, They talk about the epidemiology, how many percent of the people have it. Looks like a lot of adolescents end up having obsessive compulsive. Are you familiar with the category of differential diagnosis? How do you know it's this disease versus that one? More to the point is going into etiology. They look at the basal ganglia, very interesting structure. Remember, that's somewhat related to movement disorders. There does seem to be a genetic component to this. You can look and summarize the neuroimaging studies. Seems that there may be some glutamate gone wrong, some serotonin, dopamine, a lot of neurotransmitters obviously involved in a lot of different disease states. They talk about families as well. Kind of getting to the point for me is 407 and treatment. Cognitive behavioral stuff, which we don't get to talk about too much in this class, but that can be a very useful form. So if you could summarize that just a little bit. Psychopharmacology is to the point here. Most of the time what they use are serotonin products, serotonin agonists, which can kind of help out somewhat. Once again, it kind of shows this idea that is it just one or the other neurotransmitter. The best thing obviously to do is to combine the serotonergic products with the cognitive behavioral therapy. So I would ask that you kind of go through and summarize some of the key points in here. Hopefully from the presentation here, though, you get an idea of the different psychiatric disorders here. Depression, we talked about, schizophrenia, obsessive compulsive, and I think this ties in well with some of the stuff we talked about in the previous unit where we went in and talked about addiction, because many times for people who are addictions, they fall into these categories as well. So hopefully you've learned something here and it makes sense for you, and I would ask that you summarize this and then I'll add some comments from the discussion board. Thank you very much. Bye now.